morning, and thank you for this kind of invitation. This is the picture of my own eye, because it's my personal project since 10 years ago. My mission today is to explain the current situation about shoulder instability classification, and my challenge is to maintain your eyes open in the early morning. Good. We have to understand the anatomy, but our object is as always the same, is to obtain a functional shoulder after instability event. But the target has to speak the same language in order to we can compare results and create some guidelines for the treatment of our patients. And the problem is we are managing more than 19 classifications for shoulder instability. In 2009, we obtained a SLAR concept of the Latin American Society, and we created a different classification based on the mechanism in injuries and quality of the tissue, and was published in 2009. This is the MIQ classification, and we collected 200 cases for validated. But it's not easy to obtain the consensus of all the surgeons in the world. And this is the case of a young female with no diseases and psychiatric normal exam. She suffered her first dislocations 2 years before practicing swimming, and she has dislocation episode every day. She did a complete PT program, and I received her with 2 previous arthroscopic applications on her shoulders. This is the image of her shoulder. She has her arm with a permanent sling in abduction 45 degrees with an impossible physical exam. The EMGs was always normal. What's that? This is the difference between both shoulder. 3 capsular applications were performed, and we have a huge capsular volume and practically normal arthromeray. What's that? Where is our enemy? What can we do in these cases? It's not easy. It's in a special situation. My colleague did a Latarjet procedure, but it was a failure also. A correct Latarjet, but I didn't agree with this indication. And looking the patient from behind, you can see the scapular dyskinesia, and it's not a normal situation. We have to look the patient from behind. Stanmore introduces some years ago a new classification and a new concept related to a traumatic instability associated to muscular patterning. And we described this type of classification in the last book of the ESA group of ESCA, the ISDA, the instability related to scapular dyskinesia associated to hyperlaxity. This association between dyskinesia and hyperlaxity can create a special type of instability. And this is our proposal. We are working in this classification. The mechanism is very easy: traumatic instability, atraumatic instability, and both a traumatic event in hyperlax patient. And the M4 is the new concept introduces with this concept of IGZA. Injury, there were before many types of lesions. We have reduced this type of lesions to no bony lesions, on-track lesion. The new concept of on-track, off-track has been very important during the last years. We have to classify the injury only with these three concepts. The body defects have disappeared with the introduction of the on-track, off-track concept, and the quality of tissue. Previously, we had 6 types. Now, only good quality, weak, friable, and severe capsular defects. When we have a good diagnosis and classification, we can create treatment guidelines. And this is the proposed treatment guidelines. In simple lesions, in traumatic events, the banker repair, where we have any type of mechanism with off-track, good quality banker repair, posterior application, posterior inferior application, or interrotator closure, if you like it. When we have on-track lesions, Hill-Sachs lesions in any kind, and the quality of the tissue is pretty good, we can add the remplissage, and when we have on-track lesion plus bad quality tissue or off-track lesions, we have to perform a bone block or lateral jet or other like ligamentoplastic procedure. And it's very important in these cases of the ISDA, we have to detect them, and no surgery, only physical therapy can be our selection. Some examples: a simple lesion, only banker repair. When we have an acute traumatic instability, maybe soft tissue procedures are enough. And traumatic instability with anterior posterior lesions, the same, only soft tissue procedures are enough. In traumatic instability, posterior application, posterior inferior application are enough. On this way to perform posterior and anterior, reducing the capsular volume. We have a non-engaged Hill-Sachs on-track and banker lesion. The pattern 3, we have to add the remplissage. Maybe it's enough in my experience. And if the same situation is a good candidate for soft tissue procedures and engage remplissage. If we have an off-track lesions of bad tissue procedure, bony procedure is indicated like lateral jet. And if we have a severe anterior capsular defect, in this case after a thermal capsulorrhaphy many years ago, a ligamentoplasty or lateral jet procedure is our technique. My message to take home is we have to offer to the patient the most predictable result. It's mandatory for us to give them the best treatment for every case. The ESA/SLAR MIQ classification can help you to select pre- and intraoperatively the best treatment for your patient. And the new challenge as a worldwide concession classification led by ESCA, the shoulder section of ESCA. It will be developed in the symposium ESCA Milano, and the title of the symposium is: Are we able to create a worldwide consensus classification for shoulder instability? I have received an enthusiastic response from ESA, always ESCA, and a speaker will be representing all the arthroscopic societies in the world, from SLAR, Eddie Toy from Asia Pacific, John Tokis from ANA, Guillermo Ace, the vice president of ISACOS, Knut Breisel from ESCA, and me. I was the chairman of the ESA some years ago, and now I'm an active member of the board of SLAR. And here's the next challenge. We have a timing for the developing this classification. I hope to show you in few years. Thank you very much.